Technology is only good when it works.
That's right. Okay, so without further ado, please welcome Ms. Jenny Buckley. Thank you to everyone with ACAP for inviting me tonight, and I think very highly of this organization and find myself not just professionally but personally in this gap of unadult children of an aging parent. So I have a lot of connection to you all tonight. Additionally, thank you to our sponsors. I appreciate all the good work that you do, and I'm so grateful that you support events like this. So I asked Kelly not to do an introduction because in times when I've done public speaking, there's nothing cringier than hearing someone be like, and then she went to this school, and then she did this. I do want to introduce myself probably as a way of disclaimer to tell you that, you know, I'm not perfect in this topic. So if you came here for perfection or for absolute answers, the door's right back there, grab some water on your way out. But I do think that we can have a productive conversation, and I hope that you will contribute some of your experiences as well. So my name is Jenny Buckley. I am a registered nurse. I'll go way back to 1985 when I was 14 years old and I was diagnosed with cancer. And don't be sad, I'm fine. I have kids, I've lived a great life. But my cancer at that time, you know, things were a lot different. It required that I have a very major surgery and then I have some subsequent treatment. The surgery was a walk in the park. It was a big deal. It was an 8-hour surgery, but because of the nursing care that I had and the way that they anticipated my needs and my parents' needs, I felt like, why is this cancer thing such a big deal? This isn't so bad. When I had to have the follow-up treatment because I had lung metastases, I was in a different hospital. I was required to be in isolation, and I had care that can only be described as abysmal. In fact, you shouldn't even use the word care. My food tray was kicked in late at night. I was sick on my bed sheets and no one would help me clean it up. I was 14 years old, and I was in isolation in the Bronx. So I had a really early introduction to the importance of care in terms of what good care can do and what lousy care feels like, and how that not only affects the patient, but the entire family system. So I think I carried that with me, and then after a false start in advertising, I went into nursing, and very quickly I thought oncology would be a good field for me. But I found that working in oncology in the hospital, it was very hopeless at that time. It seemed like patients were in pain, people were scared, people were confused. Oncologists would, you know, as a generalization, round very early in the morning, so they didn't have to answer the family's questions. And I thought, this isn't what I expected at all. I don't feel like I'm making any kind of difference. The cases that really touched me were the people that we ended up sending to hospice. And I really got kind of inspired by the conversations that I observed with the hospice nurses coming in to talk to the family and the patient, but the entire family, about goals, about hopes, about things that were why I was doing what I was doing. So my career shifted into hospice and palliative care, and I did that from about 2000 to 2019, and I am grateful for every day I had that experience. I went into hundreds upon hundreds and hundreds of people's homes. I heard amazing stories. I saw incredible things. I am better for it in every way that I had that. I also managed some palliative care programs, and maybe you've had some conversations in this room about the differences between hospice and palliative care, how hospice is sort of part of the healthcare continuum. Palliative care, there's a different reimbursement structure. But what I really loved about palliative care was that it didn't have the hard line in the sand that sometimes hospice has, like, you know, a life expectancy, no treatment. It was, you have an illness, you're trying to live your best life with your illness, you and your family are coping with it, how are we gonna figure this out? And I sat at kitchen tables and in dining rooms and recliners and petted pets and purred cats and drank tea and really walked beside these families, and that was very, very meaningful to me. But because there isn't a great reimbursement structure for palliative care, those were mostly grant-sponsored programs, and when those grants went away, the programs went away. Now, there is palliative care out there. We can talk about that later if you have some questions. But I was so moved by the things that people would share with me and the circumstances that people were expected to manage at home that I really felt this calling. And at the same time, I felt like as I was, growing up, my kids were growing up, I was becoming a part of my community. Almost every night when I was driving home, I would get a call from a neighbor, from someone from my church, from someone from my children's school. Did you hear about so-and-so's dad? Or, oh my gosh, my mom just had a fall. Or so-and-so's in the ICU, he's supposed to have surgery, we don't know what to do next. And there was this massive gap of, you don't know what you don't know. And it brought me way back to that cancer feeling back in 1985 of the worst feelings are, I don't know what I don't know, and I don't know what to expect. And there's such a vulnerability about that. And then I got older and older, and I became of the age of someone with aging parents and saw what was happening to my own family and families around me. So I went out on my own in 2020 and started sort of what I call a concierge palliative practice, where I was working with people privately of how to manage their healthcare situations at home. It's become kind of a form of care management, and I've recently partnered with an agency called Personal Care. None of that is neither here nor there. All of that is to say that if I have any legitimacy in standing in front of you tonight, if I have any credibility, it's not because I'm a physician, it's not because I have all the answers. It's just because I've sat in all of those family rooms, at all of those kitchen tables, and I've talked to people just like you about their parents, about their loved ones, and we've tried to come up with creative solutions as to how to manage what's happening. And the overriding need has always been what mine always was. What do I expect? And how do I get a better handle on, I don't know what I don't know? I'm sure if I went around the room for each of you tonight, you're very accomplished people. You've raised families, you have careers, you've contributed to your community in any number of ways. But when Dad fell and smacked his nose and wound up in the ER, you were gobsmacked. What do I do? I didn't think we were here. I don't know what the difference is between rehab and a skilled nursing facility. I don't know the difference between hospice and palliative care. I can't believe they're going to send him home when he can't get himself to the bathroom, and home health is only going to come twice a week for like 20 minutes. And then you're so vulnerable. And you're still trying to manage this successful life that you built for yourself, right? You still have a job, you still have kids to raise, you still have all of these commitments. And it's like, how do I manage my aging parents? And in so many ways, that's what this wonderful organization called ACAP is trying to help you do. Tonight, what I want to do is perhaps set some of the expectations about what is normal aging. Now, normal is a crazy word, right? And if we were here, in back to school night, and we talked about what are normal kids, you'd be like, well, you can't say that. Every kid's unique, there's no normal, and there's special, and there's different, and there's unique, and so normal is relative. But what I want to try and do is apply some of my past experiences with families with whom I've worked, with patients for whom I've observed, about some of the things that you might expect, and some of the things that you might say that isn't along the expectation of normal aging. And perhaps that's something we should address because there might be a dangerous sentinel event ahead of us, or there might be a change in level of care that we need to think about. So that's what I'm all about today. And we talked about some of the objectives. These are the formal objectives so we can, be official and be formal. I just want you to come out here feeling a little bit better about when I look at Mom tomorrow, I'm going to have a better sense of, that's okay. That's how she should be at 88 versus she probably needs to see someone about that because that is beyond the pale of what we would expect. And if that gives you some kind of confidence, then I hope it was worth your time tonight. So, there's lots of physical changes that go along with aging. And because people are getting older and it is more and more common to live into your 90s, I have certain people that I'm seeing right now. I have a lady who's 103. She was in a car accident 2 weeks ago. She's great. She could probably beat me in a foot race. And I want to point her out because I'm going to make this point several times tonight. Just like with your kids, there's always an outlier, right? Well, Tommy can do it, and you want to say as a parent, well, I'm not Tommy's mom. Or if Tommy jumped off the Brooklyn Bridge, would you jump off the Brooklyn Bridge? There's always going to be someone in your parents' circle, or your loved one's circle, who is super capable, who should be driving at age 95, who can pay their bills at age 89, who does live alone at age 87. They're out there. But what we want to do is look at what the norm is and look at what's real for our loved ones. And that takes a perspective that you've gleaned over knowing them through the course of their lives, as well as knowing their relatives before them. Genetics is a real thing. And if someone's family has a history of heart disease, lung disease, it's likely that some of those things may appear in them. So you want to have a heightened sensitivity to those. Even if your parent is saying, my mother smoked 5 packs a day, I'm not going to do that, so I'm not like that. And there may have been some behavior modifications, but we do have predispositions to things. So those are the things you want to be wary of. I'm a little, intimidated that there's a pulmonologist in the audience. I love to do so. Ladies and gentlemen, but I hope she would concur that one of the primary changes we see sort of across the board with normal aging is an atherosclerosis, or hardening of the arteries, that can cause increased blood pressure, it can cause heart rate changes, it can cause heart size changes, and because we medicate some of those changes, we can have medication side effects. Now, someone who has led a very sedentary lifestyle, had probably a high-fat diet, may have a poor genetic history, is more prone to atherosclerosis than someone who has been very active, who's ate a low-fat diet, who doesn't have genetic precursors. However, one of the things that tends to drive me crazy is when I'm working with a client or a family, and the doctor comes in and says, well, we've looked at your CT results and we found a lot of things. And I want to say, stop right there. Because you weren't scanning a newborn baby. If you were scanning an 80-year-old, you should expect 80-year-old changes. Most newborn babies don't have atherosclerosis. Most 80-year-olds do. The variable is the extent. But people who've never had high blood pressure and don't have a high salt diet, aren't overweight, may start to have some blood pressure changes. That's not abnormal. It's something that you want to look at, because just because the change is normal or not uncommon doesn't mean you shouldn't do something about it. But straight up hypertension in a senior citizen is more likely than not. The other factor is, if you medicate that, what you have to be super careful about is, do we bottom out their pressure? Because whatever anyone stands up here and says in terms of statistics, heart disease is #1, colon cancer is #1, this percent, that percent, here is what you want to protect your loved one from. Take this and nothing else. You don't want them to fall. You don't want them to fall. Dying from a fall is something I see far too often, and the negative effects of a non-fatal fall are always devastating. You can look at someone and say they never fell, in the last 6 months they fell twice. If I were a betting person, I would say they've got a year to live. falling is not normal. Falling is not uncommon. What we have to work very diligently to do is prevent all the things that could potentially cause the falling. And when it comes to the issue of heart and lungs, you want to make sure that you don't medicate someone's high blood pressure so that you give them low blood pressure and they're dizzy. And you want to know if they're having any heart rate changes, like atrial fibrillation, which is very, very common in the senior population, can cause some shortness of breath, and is often medicated with blood thinners. I'm going to talk some about medication because, cause, effect. Nothing makes me crazier than when I go to Walgreens or CVS and I see thousands of prescriptions behind the counter. And I'm like, where am I living? Like, am I in Beijing? I thought I was in Boswell, Georgia. How many people are here that we have this many prescriptions? Which the answer is, it's just that this many people have this many prescriptions. So I get really about practitioners who say, you're old, you have a symptom, let me throw a pill at you. You're old, you have a symptom, I've got a pill for that. That isn't great medical practice in my opinion. But again, I'm not a doctor, I don't write prescriptions. There are medications that do a number of good things. A lot of the medications I'm talking about are the reasons why we have 90-year-olds and 100-year-olds. But always ask if your parent is being prescribed something. Is there a way to treat this problem without the medication? When will we reevaluate the efficacy of this medication in the hopes of getting them off it? If I have 2 clients come into my purview, both 80-year-old women, one's on 10 prescriptions, one's on 2, I can put money on who's going to live to 100, and it's not the one on 10. So we want to try and get people off them while also acknowledging that the body does change, and we want to make sure that we're preventing any sentinel events or problems. The skin, we tend to forget your skin is your largest organ. So when you look at someone's skin, it is a very good sort of way to assess what might be going on with their heart, with their lungs, with their kidney, because it's the organ on display, right? And if you have someone who's maybe in their early 70s, but they have skin tags, they have poor color, they have poor turgor, they have different blemishes, that's an indication that the skin isn't all that healthy. And if the skin isn't all that healthy, what does that maybe tell us about the rest of the organs that we can't see? I do feel like, again, a lot of senior citizens spend a lot of time at the dermatologist, especially this age of senior citizens who sort of came before sunblock was, so prevalent as it is now. And they're always getting this sliced off, this Mohs surgery, this, that. But the skin is a really good way to sort of assess how someone might be aging. The other thing to know is that as we age, our temperature regulation isn't the same. It can be very hot outside and we don't sweat the same. We also don't have the same kind of turgor, and so a simple wound, like a simple bump of the shin on the dishwasher, a non-big deal, can be something that makes mom go to the wound care clinic for 6 months because we couldn't get that to approximate. So we have to take precious care, again, of all the sharp edges around our loved ones, even though we want them to feel autonomous, even though we know we can't put them in a bubble, but things like falls and wounds can change the game entirely. Our bones, after age 50, says Jenny, who's 53, bone breakdown outpaces bone formation. Bone loss accelerates, height decreases, cartilage erodes. Cartilage erodes. You've seen the people in the grocery store that walk like this. I want to go around Publix and just take many senior citizens by the collar and pull them up straight. Get up straight, get up straight. The best thing we can do for our bone health already happened. Gotta do weight-bearing exercise. We've got to do stretching. I hate stretching. I do. I'm very bad. I'll probably be that person in Publix. But the reality is our bones are not the same. So again, we go back to what's the thing we want to avoid the most? Falls. I could fall down right now. You guys probably laugh, and that'd be fair. And I'd get up and be fine. But a simple fall that should just be a little bit of a tumble, a little bit of a, dwindle, can lead to a broken bone. Broken hips, broken pelvises. How many times have you heard from your friends who are taking care of their aging parents? She was fine, she was driving, she went to Pilates last week, she hosted book club, she fell, she broke her hip, she died. If you look at Kirby Smart's dad, right? He fell on New Year's Eve. He was at practice that afternoon, then he fell, he broke his hip, and then he died. Now, I don't pretend to know all the details of that, but what I can say is he was a large man. Perhaps he wasn't able to, come off the breathing machine after surgery. I don't know, there's any number of reasons. But a hip fracture with all of the large arteries that are in your pelvic and thigh area can be it. And it's so unfortunate to think about all the things we do for our good health, and a simple stumble over a rug that shouldn't have been there, over an ottoman that's out of place, and all of a sudden that changes the game. Our oral health changes a lot. I keep a list of things I'm going to talk to God about, and hopefully I get to heaven and be like, all right, there's a disparity here. If we're going to live this long, there's some things you got to sort of renew the trademark on, because they haven't kept up with the rest of the stuff. And teeth are a big part of that. It is so difficult sometimes if you see someone in advanced stages of dementia who's non-ambulatory, who's at home with caregivers, and their mouth is not healthy because they can't get to the dentist. Now, there are some dentists in this area that do make home visits, but then they don't have the same kind of equipment that you have in the dentist. So what is normal is for older people to have a dry mouth. They need to drink more. It's normal that they would experience receding gums. It's normal that their sense of taste will change. It is not normal that they continue to have teeth fall out. It is not normal for them to have extremely foul breath. That can be a sign of a different health condition. But because your oral health is, again, just like your skin, it's something you can see. You don't need a scan or an x-ray to be able to judge the health of that area. And it's so close to some of your major organs. Oral health is something we really have to support our aging parents with, because it can change everything. And then, let's say they do have, infections, abscesses, they lose teeth, they need dentures, the dentures don't fit, they're uncomfortable. What happens after that is they don't eat as much. And if they don't eat as much, they lose weight. And while we live our whole lives trying to keep our weight down, once you hit, in my opinion, age 70, you want to hold steady. You want to hold weight. You don't want to be at a weight where a strong flu, where you've dropped 5 to 7 pounds, can all of a sudden make you very vulnerable. So if we don't keep our mouth healthy, we aren't able to eat nutritiously and hold weight like we would want to. We have a lot of changes in our 5 senses: sight, hearing, taste, smell, and touch. They all become diminished. Again, the eyes have not caught up with the age that we live to these days. Almost everyone who lives past 80 has to have cataract surgery, right? There's a lot of macular degeneration. Then we have the conversations about driving and how are we handling that? And if you're not seeing well, what can you do for your enjoyment? You can't read a book anymore. Maybe you can't watch TV. There's all kinds of things. We would expect changes with sight that are slow and progressive. What we don't expect is sudden loss of sight in one eye. What we wouldn't expect is flashes or floaters that happen suddenly. Those are indicators of a more emergent problem that needs to be fixed. Hearing, oh my gosh, how is it that we can send a man to the moon and Costco still makes the best hearing aids and they barely work for anybody? I mean, the hearing aids, the trouble, they don't fit, they don't work, they're off the charger, I lost one. There's so many challenges with hearing, but here's the thing that I see so often in the communities where I work is ladies and gentlemen don't choose to wear their hearing aids, they forget to wear their hearing aids, they don't like wearing their hearing aids, but what that leads to is a worsening of their cognitive health because they become more and more isolated. They're out of the conversation, they don't hear what's going on around them, they get in their own world, and it takes what might be just normal cognitive age-related changes to the next level. So while nobody likes to be the nag to the aging parent, I urge you to continue to really chase down issues with sight and hearing. Most older adults will lose some form of hearing as they age. Most people, if they get into their mid to late 80s, will need hearing assistance. If we don't do something about that, they become increasingly isolated and less pleasant to be with. I mean, we used to joke before my dad passed away that his middle name was what? What? Dad, put your hearing aids in. You know, they lose their sense of taste or it lessens. This again can lead to some poor nutrition. Only sweet and sugary things appeal to them. So then they have poor nutrition. They might lose weight because they only eat sweets. They might have high blood sugar. So we want to encourage them to stay hydrated so that their sense of taste is as healthy as it can be so they can still enjoy nutritious foods. Their sense of smell does diminish and their sense of touch. That's why you have to make sure that they're protected from burns. Again, they don't have the quick reaction to changes in temperature like the rest of us do. In terms of mobility, muscle strength can decrease by as much as 50% from age 25 to 80 years of age. It impairs the ability to move the body effectively, perform activities of daily living, and changes to the nervous system can also affect balance. A lot of your parents are probably dealing with neuropathy. Maybe they have some diabetes, maybe they have an autoimmune disorder, maybe they've had some chemotherapy at some point in their life, but the neuropathy can change their sensation in their feet. And when your feet don't feel right on the ground, again, that can lead to our ultimate foe, which is falls. You see these older people walking hunched over with their rollators, walking so slowly. Some of the damage has already been done. If we could rewind the clock, we would do more weight-bearing exercise earlier in their life, more stretching of their low back. But there are a number of wonderful senior exercises that people of all abilities can still do. You can get on YouTube and do chair aerobics, and it can make a difference. There is a physical therapy program, no paid sponsorship here, called Physical, F-Y-Z-I-C-A-L. They are focused on balance more than just strength. So if you have a loved one who's prone to falls, I think the physical program is a good one for them to go through. Seniors need to retain their core strength. They're going to lose muscle mass in their limbs. But if we can keep some musculature in their core, in their thighs, they can probably help themselves be free of most falls. The thing I often look at in church, when I'm supposed to be paying attention to church, is I'm Catholic, so we sit up and down all the time. Priest has you sitting down. When you go to stand up, who grabs the pew in front of them to stand up, and who can stand up of their own accord? And that's what you want your loved one to do, is to be able to get off the couch, to be able to get up. So again, in terms of expectations, you do expect them to move slower. You do expect them to be stiffer. But you can mitigate some of the damage throughout their lives. They can continue to do exercises, strengthening, stretching for as long as they live. It's just how you do it and how safe it is. And then finally, not finally, but one of the last physical changes that we have to address is the elimination changes. Because of hormonal changes that we would expect, because of muscular weakness that we would expect, individuals in their advanced age have less ability to hold their bladder and less ability to have regular, what they call morning constitutions. People tend in later age to be dehydrated. They get dehydrated for a lot of reasons, not the least of which is they don't want to be cold and they don't want to have to pee. So they don't drink water, but then they can't poop. And then they want to take a laxative, but there's nothing in them, and then they cramp. And then there's diverticulitis, and then there's impaction, and there's a whole myriad of changes. So again, your expectation should be your aging loved one is going to need more trips to the bathroom. Your aging loved one is going to probably deal with constipation more regularly than they might have as a young person. But you can do things with encouraging hydration, with fiber in their diet, again, with exercise. They don't have to run the Peachtree Road Race, but they gotta get moving so that they can keep their bowels moving. You also have to be aware that because their bladder strength is not the same, they're probably gonna get up 1 or 2 or 3 times per night to use the bathroom. So what do you wanna do? Make sure all the throw rugs are gone. Make sure there's lighting as they go to the bathroom. There's nothing unexpected along their pathway, because that's the #1 time people fall, is on their way to the bathroom in the middle of the night. And we want to save them from that. Oh, the mental changes. So many mental changes. Here's one of the frustrating things is older adults, though they might not like to talk about it, can see in themselves. They don't move as quickly, they don't see as well, they get more winded easily. They're really reluctant to admit, or perhaps unable to have the insight that cognitively they're not the same. So I'm guessing that if you're here tonight, some of the challenges that maybe some of you are up against is, how do I get mom or dad to recognize that they need this help that I'm offering? How do I get them to see that they shouldn't drive, that they have to use the walker all the time, that they need a caregiver, that these things have changed and it's not the same? And what's fascinating to me, and if I had the fix for this, I'd be a billionaire, is the dynamic between parent and child never changes. You can be a completely accomplished adult, you can be a master of industry, you can raise your own family, you're still your parents' little kid. And they, for the most part, aren't gonna listen to their kid tell them what to do or how to live their life. Even if you're getting their groceries, paying their bills, you're doing all these things, and you do it happily and gracefully, willingly, but when it's like, hey, I think we need to think about, oh, you're not gonna tell me what to do. That's where the biggest challenges are. All of the physical related changes are their own set of challenges, but it's the cognitive changes where you really start to rub up against how it's different and how your dynamic impacts it. So cognitively, you expect an older person to not be as mentally quick, not be as quickly able to retrieve dates, to retrieve times, to recall an event. That stuff I think is normal. They walk into a room, they forget why they went there, they can't remember where their readers are. These things are to be expected. When they really start to forget appointments, even if they've had them written down, when they put things where they don't belong, when they get agitated, making a decision that shouldn't be a big decision. What do you want for lunch? Do you want to see Wicked or do you want to see Gladiator? You know, when they start to snap at that because that feels like they're cornered and they're vulnerable, those are different kind of mental changes. When they become more impulsive or they show increasingly poor judgment, our frontal lobe is where our inhibitions lie. And when you have some dementia that is in this area of the brain, you lose your inhibitions. And all of a sudden, dad came out in the family room without his pants on. You know, mom started saying things she never said before. There might be inappropriate comments made about someone's appearance. They lose that inhibition. Someone who's had beautiful social graces throughout their whole lives, that's something where it's like, this isn't just aging, this is a neurological change that we might want to investigate. When people start to get lost and they can't navigate around familiar environments, that isn't the same thing as, oh, I know you just told me your name 5 minutes ago and I can't remember it. I'm saying this because if forgetting your name after 5 minutes means you have dementia, I gotta go. I'm in big trouble. But if you can't find your way home, if you can't follow a thread that seems very simple, those are times where it's like, perhaps we should go in and see the doctor and just get a baseline memory score. I say that so simply. That's like pulling a pin on a grenade and rolling it into the Thanksgiving dinner table. You want to get memory assessed early and often so that you can have a really legitimate, credible conversation about the changes that are happening. So that if you have to make adjustments to a living situation, a caregiving situation, a driving situation, a power of attorney situation, you need to be able to support it with more than just, come on, Dad, you and I both know it's true. Because again, they're still a kid and they're not going to see it that way. In addition to aging, there's lots of things that complicate the cognitive picture of our aging loved ones. Like I said before, they're probably on more than 10 medications. Blood pressure up, blood thinners down, you know, this for their prostate, this for their bone health, this for their mood, this, and all of a sudden they're so medicated, you know, their tox screen would be crazy if you had them pee in a cup at the emergency room. We're flooding our seniors with pharmaceutical solutions. We're trying to offer pharmaceutical solutions when sometimes we just need to look at what's basic, what's real, and how we can support them. They have hormonal changes, they have changes in their blood chemistry, and then very often, I was with a lady this afternoon, she had a very bad fall back in March, and that she probably had some underlying dementia before the fall, but it really wasn't detectable. That traumatic brain injury that she had just absolutely put the foot on the gas in terms of now her really not able to have a coherent conversation. So if they've had some head injury or some other kind of trauma, that can create some of the mental changes. There's another big thing I don't think we talk enough about with our aging loved ones is the prevalence of anxiety and depression. You know, serotonin is one of our feel-good chemicals, and we start to produce, our brain starts to produce less of it as we age. So even if you are the most naturally optimistic, happy-go-lucky person, otherwise healthy, going into your senior years, you're going to start to have less serotonin production. Now, do you have enough of a dip in that you require medication? Not for everybody, but we overlook depression in older adults because they're just getting crabby. They're just irritated that I'm bugging them. The chemical depression in older adults is a very real problem. And if they've had some kind of neurological event like a stroke, it's that much worse. I get really, as much as I sit up here and say stop throwing pills at old people, if I see someone who's come out of rehab after they've had a pretty significant stroke and they're trying to integrate back into their home setting and they haven't been prescribed an antidepressant, I have my eyes on them because I think they're really going to struggle. They just aren't themselves in their own head. You know, and then you take all the practical things. They don't look as good anymore. They don't feel as good. They have to pee all the time. They can't do all the things they want to do. It's not a cakewalk. I mean, it's no joke. So you take the practical reasons for things that they might really be sad about, and add to that some of the normal physiological chemical changes that is happening in their brain, you're going to wind up with most of our senior citizens who are really clinically depressed. Substance abuse issues is also a major thing that isn't talked enough about in the elderly. And while I do love my Chardonnay, and I am no stranger to a cocktail, you go into those assisted living facilities, you see those happy hours cranking up at about 3:30, you're like, it's party time. But truly, this was the generation where, you know, the husband went to work and the wife made dinner, and then they came home and she poured him a scotch and he made her a highball, and that's how they sat and had their time, and that's great. No judgment. But they would probably weigh more and eat more and metabolize differently. And now they don't have things they have to wake up for, like the job. And so instead of one Manhattan, now it's two Manhattans. And it's just something to keep an eye on, because, you know, we all know that alcohol abuse is a way of self-medicating certain problems. And if you have someone who's depressed about their own lot in life and maybe having some chemical changes in their brain, it wouldn't be the first person in the world that would, you know, turn to something different. This is also very sad, but men ages 85 and older have the highest rate of suicide in the country. So if that doesn't underscore the problem of depression, these individuals are feeling helpless and hopeless and don't have the toolkits always to be able to communicate the desperation they're feeling. I will not soon forget the day that I worked at St. Anne's Terrace, where we had a couple that we were looking after, and the lady had some dementia, and the gentleman had fallen and broken his hip and came home from rehab, and he sent our caregiver to get the mail, and he shot his wife and he shot himself. Just didn't see any way out of his situation. And it was devastating, but in hindsight, it wasn't totally unpredictable. He just felt hopeless. Anxiety in the elderly is also something, I'm just guessing at least one of you in here has a parent that gets hyper fixated on some particular issue and can't seem to move the needle over the skip in that record. Whether it's, you know, but we always have the yams at Thanksgiving, but it's not the same recipe, and they just, and I think it truly is that sort of fight or flight instinct where the older people feel like, I can't protect myself like I used to. You know, this part of my limbic system in my brain still knows, is telling me I'm vulnerable. And so I am afraid of more things than are reasonable. But it's a way to express this fact that I'm scared. I'm scared I can't defend myself. I'm scared I can't protect my loved ones. I'm not the strong, able-bodied person I used to be. And how that manifests is on the 16th phone call you got from your dad asking if the taxes have been paid. And you're like, I just told you. And it's not just a matter of, did he forget that he asked you? It's a matter of, he has to have this constant reassurance, or mom has to have this constant reassurance, because all of a sudden she or he, who's been capable and competent in managing their own affairs for their entire life, can't anymore. And for some reason, but again, if I could find out why and find out how to fix this, they can't just say, I'm so scared. I'm not the same person I used to be. Very few people are able to share that with their loved one at a time that can help them take away that anxiety, when you can say, Mom, I got this, it's okay. Because it just feels so out of the natural order of things. So we've talked about how to gauge, you know, throughout this, what's normal, what's not uncommon, what's abnormal. You know, that's how you need to, when you observe something in your loved one. Is this normal? Is this just kind of where we are right now? Is this not uncommon? Well, all right. Some people aren't dealing with this, but this is where we are. I can try and work with this, or, you know, this is our new normal. Or is this abnormal? This is an acute and sudden change. This is an absolute disruption to their quality of life. And I need to take my loved one into a healthcare professional to see if we can change course. You know, you have to help avoiding comparisons, like I said before, is probably the #1 way to help yourself, help your loved ones. You know, we say it to our kids, we say it to ourselves. Comparisons are the killer of joy. Your parents are always going to come back and say, she drives, he pays his own bills, that's fine. You have to work with what's real for your loved ones, where they are, what they can manage, what they can't manage. And no two are created equal. Sometimes there are 90-year-olds that can do things that 70-year-olds can't. It just depends on so many things inside that person's chemistry that we don't know about. Just like with our kids, sometimes it can be frustrating. You know, you can look at others and be like, why can't you do that? Why are we having so much trouble with that? And that's just being honest. That's human. This is all human stuff. It can be icky and messy, frustrating and disappointing, and you got to give yourself grace for all of that. But when they can't, they can't. And so you just meet them where they are, and you do what needs to be done. We spend so much time, we've spent the last almost hour, talking about how to help your loved ones. And I want to close on the fact, before we get to questions, I really challenge each of you to think about ways to help yourself. You know, I work with so many families, very sadly, wind up feeling like, I wish you would just go. It's just constant problem with mom. Or he's so unhappy, I just wish he would just pass because there's nothing left for him here. And those are honest feelings too. But we really can't push the timeline any faster than it's supposed to be. So how do you help yourself? What's the kind of self-care that you can back up and do? And I think attending groups like this is a great first start, because misery loves company and you're among friends. But, you know, it's very, very challenging when you had toddlers running around and everything was chaos. You could eventually pick them up, put them in their room, shut the door, they could scream their living head off, but it's like, you're safe, you'll fall asleep, good night. I love you. But then mom's, you know, in her apartment 15 miles away, and there's an oven that turns on, and there's bottles of pills, and there's throw rugs, and there's all these kind of things, and you're supposed to go home and cook dinner for your own family and go to work the next day and be like, she'll be all right, right? It's really scary. And no one's done it like this before, right? Like, the generations before us didn't have parents that got this old and that had this many options and freedoms. So again, give yourself some grace for that. It's really hard. And we're trying to parent our parents differently than they parented us. I mean, I don't know how old you are, but I was that kid who was like, I'll call you for dinner. I better know that you're home after dark. Like that ad, it's 10 o'clock, do you know where your children are? Was for my parents. Because I was out riding my bike. You know, they were just like, she'll be fine until she's not, and then we'll hear about it. And now we're trying to do our kind of parenting to our parents of the more nurturing, enveloping, bringing in, and some of them bristle. They don't really want that. That's not their love language. And that's a personal thing that only you and your loved ones can figure out. But, you know, when I work with families, and I'll close on this, I feel like if I can do nothing else for them, sometimes I try and tell them, you're not crazy. There is no door number 3 with the better option. This sucks. It's really hard. It's really unfortunate it played out this way. The choices are not great. You are thinking about all the right things. That's what it is. And so I want to give each of you kind of that encouragement as well. You know, when people just say, I just want mom to be happy. Well, let's not let happy be our first goal. I want mom to be safe. I want mom to be as content as possible. Their happiness is not totally in our control. So anyway, that's getting very heavy. But I want to leave time for questions, and thank you for listening.
Questions? Lots of questions. I've got a lot of stuff swirling in my brain. Anybody? Wow, really?
Because I answered everything.
I know.
I'll figure it out now.
I'll ask one of my questions. So, Jenny, when you talked about taking them to a healthcare professional, something that I've noticed with my own aging mother is we're playing whack-a-mole with all these things, and we want to medicate all these things. But Dr. A and Dr. B and Dr. C, unless you're in a healthcare system where they all have a chart and they all compare, that's not always the case. How do you get everybody on the same page and say, well, you know what, she's dealing with this, and we're medicating this, and is that a drug interaction? And how do we, what do we do in that case? Thanks for starting with me.
I know. Ladies and gentlemen, my former friend, Kelly. You know, that you just have to, you're not gonna like this answer, you have to go to every appointment, and you have to be their advocate, and you have to learn medical things that you never thought you'd learn. And, you know, I am not one to sit up here and doctor bash. I'm not a doctor, I don't know what that, you know, is like, but I, with my own family and then with my clients, I attend lots and lots of doctor's appointments. I used to think when I started as a care manager, doctors would be like, what's she doing here? Why they're like, thank you. Please tell me, please explain it, because I don't have time, or I don't have the words. So, you know, if you can't go to the doctor's appointments, find a care manager, find someone who can. These portals, don't get me started on these portals. I mean, they are gatekeepers. Older people can't keep track of their usernames and their passwords, and they don't know how to access them, and all these things. And I understand how difficult it is to be in a doctor's office and all the phone calls. Again, I don't have the answers, but to that question, even if they are in the same healthcare system, our medical, one of the many things that drew me to palliative care and hospice was the comprehensive nature about it. Because healthcare is silos. You got the cardiologist, the nephrologist, the oncologist, the pulmonologist. You got them all. And, you know, sometimes you have that wonderful physician who reaches across the bridge and says, hey, let's do this together. But you have to say for your loved one, because also our generation of parents don't question doctors. They still have, you know, mad respect for the white coat. And I have respect for it, but, you know, doctor, I understand that you're concerned about this problem, but it's really this problem that's impacting her quality of life more. So if we're going to medicate one, I'm really more interested in looking at this situation. You know your loved one. You don't have to be a nurse, a doctor, to know what your parent needs, what your parent's struggling with. So just go into it knowing they are operating in silos. But they will, my experience has been, most physicians will listen to a dedicated caregiver saying, hey, this is really what I'm looking for. Not expecting you to solve all of this, I just need this problem addressed.
So advocate.
Advocate. Yes.
Anyone, question?
You had indicated to get memory tested early and often. What does that look like? I go to the doctor with my dad, and they give him 3 things to remember at the end of the conversation. What were those 3 things? Draw the hands on the clock out. He does fine with all that, but I'm seeing decline, right?
I know. Well, there are different tests. One's called an ACAP, I think, and you know, and then there is a different mini-mental. There's mini-mental and the ACAP, and they're more than just 3 questions. But you're also not the first person that ever says to me, yeah, they do great on that. And then they go home and they think that they can, do this, that, and the other thing, and it isn't a perfect system. Sometimes something will change, a minor reflection that will just add to your case. But if I stood up here and said, well, you'll just get it tested early and often, and then you'll be able to prove that it doesn't always work that way.
Medicare does cover the mini mental. It's usually more than 3 questions. And so, but you have to ask for it. For some reason, it's not something that's offered in a primary care office. You have to ask for it. And I would say, yes, definitely sooner, the earlier the better. That way you do get that baseline, for sure. It's a great question. Yeah. Anyone? Yeah.
And the doctor asked Mom a question and she answers, yes, I manage my meds just fine, and she doesn't. What am I supposed to do while I'm sitting there going like this? What do I do?
Because I sometimes have my own suspicions when I meet a patient and I'll look at the daughter, I'm so sorry, I'll look at the daughter, the person who brought the patient in, and I'll say, okay, ma'am, I'm going to say these things directly to your daughter and they are about you. So I've just met your mom and I'm concerned that she has some memory deficits. And the daughter was like, really? She's always been like this. And I'll say, so normally when I ask a question about X, Y, or Z, the response would be this. And I said, I'm very concerned, and I will jump the gun and refer patients and families to neurologists or psychiatrists because I have concerns that even the family didn't pick up on, which makes me super scared. But whenever I have a husband, a wife, or I have a daughter and a son, and the patient's telling me things, and I know in the back of my brain that I've seen in the medical record, you've been to the ER 99 times for these things, it looks like the blood pressure is doing all kinds of things. I'll look at the daughter and say, oh, so your mom's managing all of her medications. No, I think we need a pill box, and I make sure this, that, and the other, da, 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 da. And the daughter, I had one patient who was like, oh, I don't remember that. And so it's sometimes it's subtle, and sometimes you have doctors that are a little bit more aggressive and more concerned about that. But I like to partner with other doctors, and I don't like people falling through the cracks because it happens all the time. I worked in the hospital as an ICU doctor, and I saw people with hip fractures. And for me, as somebody who's not a geriatrician or experienced, to say, your mom broke her hip, and the chances of her
Breaking the other one.
or not surviving this hospitalization are this, and the family looking at me very angry and very hurt and very upset, and I'm like, I'm not trying to scare you, but hip fractures and so many hurt injuries was extremely serious, and things are gonna change for her after this hospitalization. And I need you to have a primary care doctor or somebody who can take over, because yeah, so it gets scary, but doctors don't do a great job, and I know we don't do a great job because we get busy. I get yelled at because I spend 5 hours with one patient, but I'm always concerned I'll miss something. And if someone doesn't have a PCP and they have a lot of medical problems that I'm discovering, I will pull up my phone and say, I'm gonna text the doctor. If you're willing, I can get them in to see you like in an hour. And I have referred patients to PCPs and have them seen the same day that they've seen me, because something's falling off the cracks and we need to help each other. And then I'm lucky to find other doctors who are family doctors or cardiologists who think the same the way that I do, and they would text me and say, hey, I just saw that patient you sent me, this is what's going on, blah, blah, blah. I'm like, that's what I need. I need people I can trust to take care of my patients, since I need them to trust me. And if I'm not taking care of them, they won't come back, and that'll happen enough of that. So it's, so you're right. We've missed it all. And I was a nurse for 10 years before I was a doctor. So I have a perspective. So I'm used to translating doctor speak to patient speak.
Mm-hmm.
So it's a process, and it's very difficult, and it's really hard to people struggle because doctors aren't doing their job.
The other thing I would suggest, everything Dr. Brown said is spot on, and that's, best practice. I do have some clients who I know are a little testy about, their pride. And, typically when you bring someone to the doctor, the nurse or the medical assistant brings them in, takes their vitals, asks, please, here's still your medications, and then they go out and say, I'll get the doctor. I am famous for saying, oh, I need a tissue. Going out and following that person and saying, my mom is a poor historian, please let the doctor know that I need to be asked the same questions.
And if your parent is so particular like mine, that you're not speaking to the patient, you're having a conversation with my daughter. Sometimes an email at a time will help you ask for or a written list, and like you said, or ask for a separate appointment, say, I will be your house for my mom, and you'll be able to come back and see you. You've got to figure out what the game is, but they really want to hear from you.
Any final questions? I know we've gone over, so we want to be very respectful of your time. Anyone? I know we've got a couple of giveaways from our, couple of our sponsors. So if we want to go ahead and you guys want to come up for that. And then Jenny, if anybody would like a copy of the program, the PowerPoint presentation, please reach out to Christian or myself and we can get that to you. And then if anybody would like to get in touch with you, is that possible?
Absolutely,
Your
just
service.
put my cell number right with the distribution of them, I'd be happy to talk to anybody. I really appreciate